Every time you step foot inside an American hospital, your medical history, your lab results, and your insurance billing codes are gathered, digitized, and locked away inside a single company's software. This chart breaks down the U.S. acute care hospital market, showing that roughly 44% of beds run on Epic Systems software. On a population level, that means Epic holds the deeply personal health records of more than 280 million Americans. This digital empire is managed from a massive, continuously expanding corporate headquarters in Verona, Wisconsin. Epic operates as the central infrastructure for American medicine, controlling everything from surgical schedules to multi-billion-dollar billing cycles. Now, the federal government is formally looking under the hood. Reports show the Federal Trade Commission has opened an antitrust investigation into the company. Regulators have issued civil investigative demands to other health tech companies, trying to determine if Epic systematically uses its market dominance to block rivals and restrict access to patient data. The FTC probe lands on top of a major antitrust lawsuit filed by the Texas Attorney General and a legal fight with startup Particle Health. For decades, healthcare antitrust regulators spent their time scrutinizing hospital system mergers and insurance consolidations. The focus has completely shifted. Regulators are targeting digital infrastructure as the primary monopoly threat. This flowchart illustrates the financial architecture of a modern health system. Implementing an enterprise health record is usually the single largest capital expenditure a hospital makes in a generation. A mid-sized network will routinely spend $100 to $300 million just to install the software. Once the initial purchase is made, hospital IT departments spend years on workflow customization, building highly specific chart templates and hardwiring their revenue cycle rules directly into the system. Then they have to retrain thousands of nurses and physicians to use this exact interface. Attempting to rip the system out after that point guarantees clinical friction and immediate revenue cycle failures. At the highest end, large academic institutions like the Mayo Clinic has spent upwards of $1 billion on their Epic rollouts. This creates a state of lock-in, where the financial and operational risks of leaving outweigh the benefits of any alternative software. This dynamic creates what industry insiders call the all-in-one default. If an independent startup builds a highly effective AI documentation tool or predictive analytics engine, health system CFOs face a dilemma. Integrating the outside tool requires difficult technical hurdles. The hospital is locked in. Rather than fight the friction, they default to buying whatever native add-on Epic offers, even if it is functionally inferior to the independent startup software. When health systems do try to connect third-party platforms, they hit the EHR toll booth. Startups face steep custom build fees, restrictive API throttling, and massive technical hurdles to aggregate clinical records. Epic defends these practices vigorously. The company maintains that its strict data governance rules are required to protect HIPAA compliance, patient privacy, and defend hospital networks against bad actors harvesting records. It's the exact playbook pioneered by companies like Apple and Google to protect their proprietary ecosystems. By acting as the sole gatekeeper under the banner of cybersecurity, a dominant platform can set arbitrary rules that conveniently disadvantage independent competitors. Epic claims they lead the charge on data exchange through their Care Everywhere network. Hospital records have moved between two large hospitals running Epic. It works smoothly, but step outside that ecosystem and you hit the interoperability illusion. Exchanging contextual clinical data with a small rural clinic running an independent platform often results in formatting errors and an avalanche of completely unsearchable PDFs. This node map demonstrates the contrast between external friction and internal aggregation. Epic has built a proprietary research database called Cosmos, which currently pools the longitudinal records of over 310 million opted-in patients. When a vendor controls the hospital's infrastructure and acts as the ultimate referee for data sharing, the line between protecting patient security and maintaining anti-competitive vendor lock-in disappears. Hospital records have moved beyond administrative billing. Today, longitudinal data pipelines provide the raw material for predictive diagnostics and clinical automation. Hospitals want to deploy specialized clinical decision support and predictive triage algorithms, but those tools rely entirely on gaining access to this tightly locked data pipeline, which brings us to the core question the federal government is trying to answer. Can one private software company sit at the center of the country's clinical data pipeline and dictate the terms to everyone else? The outcome of these legal battles will determine whether regulators mandate standardized, open-access API pricing or enforce unbundling rules that give health systems the leverage to buy independent software without facing massive integration penalties. The digital infrastructure underpinning American healthcare is consolidated in a few private hands. How that data is accessed is a matter of deciding if patient information is a proprietary vendor asset or an essential public utility.